Okay, so good morning and good afternoon if you are in Europe or in Asia. I am from France, so we are in the middle. I would like to share with you the result of the first in-human trial of mini-jet implant in glaucoma patients insufficiently controlled by topical hypertensive medication, mainly of those having a mild to moderate stage. The primary endpoint was the IOP reduction at 6 months, but this report describes the efficacy and safety outcomes observed after a 2-year follow-up period. It was the first in-human studies following the animal studies, and we wanted to check if the technique was safe and effective as an outflow pathway through the supraciliary space. It's important to say that there is no cataract surgery at inclusion or during the follow-up period. It was a standalone surgery. There was no washout at the inclusion of the medication, and all the eye drops were maintained or stopped according to the postoperative IOP. The patients were selected in 2 countries, India and Panama, and the surgeries were made by Heike Ahmed from Toronto, Christoph Ernais from Munich, Germany, and I, your humble servant. At this time, the surgeons were able to fly into these clinical sites to perform the surgeries, and I would like to thank personally Professor Reddy in Hyderabad for his kind welcome and support. Panama and India are the top sites used for the US and Asia as the training centers. As you can see, we have also an independent international safety monitoring committee overseeing the study. To be included, patients should be at least 18 years of age, having primary or secondary open-angle glaucoma defined according to the Schaeffer grading system. And this glaucoma patients were not adequately controlled with IOP between 21 to 35 millimeter of mercury using one or more topical hypertensive medications. The study excluded patients with neovascular glaucoma, with visual field defect in the 10 degrees central field, and with an history of glaucoma surgery. The other exclusion criteria were very classical for this kind of study. Demographic data for the study population is given in this slide. Patients were evenly divided between genders, and a mean age of 60 years, were of diverse ethnicity, and I have to say there is no Caucasian patient in this group. Half of the patients were pseudophakic, and 44% of them were using only one IOP lowering medication class at the time of surgery. Our baseline IOP, 23 millimeter of mercury, was under medication, and of course we think that a washout will show baseline IOP to be even higher, but we keep the treatment during the study. You can see the result. A baseline IOP was on the medication, 23.2 millimeter of mercury without washout at baseline. And follow-up period were obtained from the full population, both with and without medication. There is no additional glaucoma surgery during the follow-up over the 2-year period. We can say that we obtained a good efficacy of the mini-jet implant with a final IOP of more or less 14 millimeter of mercury, which correspond to mean 41% reduction in pressure from baseline. And I have to say that 48% of the panel were drop-free after the 2-year period. It's very important. At month 24, the mean medication number was only 1.1, and there is no need for subsequent glaucoma surgery, as I said before. You can see the medication usage before and after 2 years, and you can see at the baseline, at the inclusion, 56% of the patients were using 2 or 3 medication or more, and this percentage declined to 29% at 2 years, which is very significant, of course. You can see that is a result in the two population, the population which stops the medication and the population we stay on medication during the follow-up. Mini-Inject has been effective in both groups, with the med-free subgroup doing even better than the patient on meds. But you can see that if you see the curves in the on-med groups, they are also doing well with a final pressure of 30 millimeters of mercury. The safety is, of course, very important when you use an implant which is very close to the cornea. So we did not observe any clinically relevant changes in the endothelial corneal cell densities, both in the center, -5%, and in the periphery, -6% from baseline. So, of course, long-term monitoring of this density is very important due to the CyPass data with in the COMPASS study. And we also observed that no Mini-Inject patient showed a 30% ECD loss at any time point during the follow-up. And this 30% percentage of corneal endothelial cell loss is usually seen as a threshold for safety, and the FDA defines this threshold as a safety concern. And you can see that with the CyPass and with the iDRUS, we can have this kind of problems with significant loss of cells with the risk of persistent corneal edema. And in our study on 2 years, we didn't observe any kind of this problem. So it's very important. Of course, we observed some adverse events which were very common for surgery, for the anterior segment surgery, and also common for mix. But these adverse events happen in the early postoperative period: transient inflammation, elevation of pressure for usually in relation to the viscoelastic. And we observe 3 patients with visual acuity loss, and 2 were secondary to a progression of the cataract, because half of the patients in inclusion were not operated by cataract. But we did not observe any important adverse event after the surgery. And we didn't need to do some extra additional glaucoma filtering surgery. And I have to say that this technique is internal. We have no bleb, so you don't need to manage the bleb after the surgery. We published the 6 months result in a recent issue of Ophthalmology Glaucoma Journal, and the 2-year results were in good line and consistent with the 6 months result, with a sustained IOP reduction between 6 months and 2 years. There is no trend of reduced efficacy between six months and 2 years. So in summary, I would like to say that this first 24 months, first in humans trial, met the primary endpoint of significantly lowering IOP at 6 months compared to baseline. The result of this study demonstrates that Mini-Inject glaucoma drainage system lowers IOP by approximately 40% after 2 years, and eliminates the need for medication in nearly 50% of the panel at 2 years, when implanted in a standalone procedure. In this pilot study, we didn't observe any serious ocular adverse events, or no eye required secondary surgical procedure for glaucoma. So it's very encouraging, and I think that the STAR material causes minimal inflammation response, or maybe one of the reasons why we observe these encouraging outcomes. And I hope that this outcome will be sustained in the longer term.
Thank you so much, Philippe, for the presentation and reviewing these results. You know, the publication is out there, as you mentioned, and we're looking forward to seeing 24 months published as well. And thank you for just summarizing some early results that we've seen. So I think what we'll do is we're going to maybe go to Julián to present the STAR 2 results, and then we can maybe come back and talk a bit about some of the questions that have come up. I think that there's some good questions to ask as well. So Julián, if you could prepare and tell us about the STAR 2 results, which is the European trial now, and some of the early findings. Thank you, Julián, for being here.
Well, thank you again, everybody. So, well, I think that it's been very clear now that when dealing with the suprachoroidal space, well, one is power with control. So power comes from the potential of the suprachoroidal space itself, and control is supposed to be provided by the material of the mini jet. So you've seen the results of the STAR 1, and basically the idea with this STAR 2 trial is to confirm the results of the previous one in terms of safety and, let's see, safety and IOP reduction. So those are my disclosures. So the design is very similar to the previous one. I'm not going to take much time on this, but again, it's a standalone procedure, mild to moderate primary open-angle glaucoma, and in this case, we enrolled 29 patients. So across these different sites, 1 in Spain, 2 in France, and 5 in Germany. So again, inclusion criteria are very similar. Again, primary open-angle glaucoma, patients had to be a little bit older than in the previous one. They have to be older than 50, but very similar. And again, the study population were patients which were not controlled with at least 2 meds. And endothelial cell density has to be higher than 1/1500. So, and this is an important criteria because we are all concerned with the endothelial cell density and what can happen with these devices. So nothing relevant in the demographics, just to mention that 70% of the population were women, so female. So it's, well, I don't know, that's how it went. There was no bias in this case, but there's this 1/3 of the population were male only. And the primary endpoint definition is very important. So we try to define the qualified success rate after the surgery and define as the pressure has to be between higher than 5 and lower than 21 with a reduction of at least 20% from baseline. And this is important with or without additional meds. And obviously, we are presenting today the 6 months results, so it's the qualified success after 6 months. So 76% of the patients met the qualified success rate, and this is very important, and it's more relevant that 55% of the patients were medication-free. And this, if what the previous study is true and is confirmed, but this second one, it's supposed to be very stable after the 6 months, the IOP and the success rate. So let's see what happened in the 1 year, with the 1 year results. Remember that the pressure went down from 24, almost 25, to 14, and remember that there was also no washout at baseline. So it's a 40% reduction, And also there is a reduction in the number of meds. As you can see, almost 60% of the patients were on more than 3 meds pre-surgery, and after the surgery, 55% of the patients were off meds, and only 17% were on 3 meds. And this graph is also very interesting, in my opinion. And you can see the patients which were medication-free, also they had a mean pressure around 12. So it's very, very low pressures. And this is what we might expect from the suprachoroidal drainage. And then those on meds, the decrease of the IOP was almost 24%, from 24 to 18.1. And this is also very important. We've been talking about how the material is important and how it's important that this is soft, and it's very clearly shown in these UVN images. This is the one on the left is after 1 week, and you can see how it sits on the ciliary body, and you may see these dark areas which corresponds to the aqueous there. And after 6 months, you can see how the device is bent and it's adapting to the scleral curvature, and is far away from the corneal endothelium. And this is very different if you compare it to the CyPass. The material is is not soft, it's rigid, and it tends to, when in place, it tends to go closer to the cornea. And if you remember any of the UVM morosity images that have been published with the CyPass, the difference is very, very clear. So the good thing is that it adapts to the scleral curvature. And also there is no migration, so it stays where it was placed. So adverse events, obviously there is no risk-free surgery, so there are additional surgery, glaucoma surgery was needed in 3 patients, and this is a difference from the previous study. But there were no safety concerns with the corneal endothelial cell density, and more importantly, that's something that we all fear when we're dealing with the suprachoroidal space, no hypotony, no long-term hypotony. So is very safe. So in summary, so there is a reduction in the IOP, and the medication is very clear. 40% reduction after 6 months, and you've seen the difference between even the reduction is higher in the case of patients that were on no extra med. The pressure went down to 12. No major safety control regarding the corneal endothelial hypotony. There were no changes or no displacement of the mini jet. So I think it's fair to say that it's a good bleb-free procedure. We just know this 6-month data, so obviously we need more longer term data, but it has the potential to be beneficial for not only patients with moderate, but maybe a little bit more advanced glaucoma. Thank you, Ike.